Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Welcome. We're here today with Dr. Cara Mack, who is with the University of Colorado School of Medicine. And Dr. Mack, would you like to tell us your roles there at the University of Colorado?
Sure. I'm a professor of pediatrics in the Division of Gastroenterology and Hepatology. I am the medical director of our Pediatric Liver Center, and I'm also the director of the training program for pediatric GI and liver disease fellowship training program.
So, of course, one of the things that you're doing, I guess primary sclerosing cholangitis would only be one of a number of illnesses that you deal with.
Yes, we see kids with all kinds of liver diseases, from infectious causes to congenital defects of the liver and the bile duct, as well as autoimmune diseases such as PSC.
Would you say that is there a rise in autoimmune diseases in children at the moment?
You know, really, honestly, it's been for the past almost 2 decades, there's been the observation that autoimmune diseases in general are on the rise. And that's based on the observation of the incidence of many autoimmune diseases increasing over the past couple decades, as well as in the setting of a decrease in major infectious disease incidents. And that observation led to a hypothesis called the hygiene hypothesis, whereby in the cleaner environment that we all live in, the immune system is not properly educated and it can't differentiate very well self from non-self, and that results in appropriate immune regulation and the increased risk for autoimmune diseases and autoimmune responses. So specifically for PSC, there isn't a lot of literature to suggest that that particular disease has increased in children. However, there was a recent study suggesting that the incidence of PSC in adults is increasing, and that study or report I saw recently from the northern European countries. For children, we know another autoimmune disease called autoimmune hepatitis. There has been between 1990 and the mid-2000s, that autoimmune liver disease has slowly been on the rise as well.
And other than the hygiene hypothesis, is there other theories as to why autoimmune diseases, what causes them?
I mean, most autoimmune diseases, it's presumed to be multifactorial, that you start with a genetic predisposition to the disease, where based on your genes, and HLA genes are the most commonly associated with autoimmune diseases, that you're more at risk for developing autoimmunity. And in addition to the genetic predisposition, then the theory is that there is a trigger, whether it's an environmental trigger or a virus infection trigger, that starts the damage to the organ. In the case of PSC, it would be a trigger that starts the damage to the bile duct epithelium. And then you have an abnormal immune response that becomes autoimmune in nature, where you have this chronic inflammation that continues attacking the target organ, which in PSC, it's the bile ducts. And then that chronic inflammation eventually leads to scarring, and in the case of PSC, cirrhosis.
Once you get the original scar, that your immune system keeps trying to heal that scar, but causes more scars doing so. Would that be correct?
Yeah, or that actually it doesn't attempt to heal it, that it sees the bile duct cells as foreign and not part of self, and continues the attack on it, thinking that it shouldn't be there, and is causing direct inflammation that then subsequently scarring happens after that. So it's an abnormal, persistent immune-mediated response targeting the bile duct epithelium. In addition, specific to PSC, there are theories that not only is inflammation playing a role, but the bile acids that are stuck in that liver, because the bile doesn't flow well in the setting of PSC, that those bile acids can directly damage the liver as well and contribute to the scarring. So it really is multifactorial, many different processes that culminate with the final result of damage to the bile ducts and the scarring.
Yeah, which is why it's so hard to cure, I suppose, there's many different things going on. What sort of treatments, I mean, what sort of treatments do you are available to children or, in pediatric PSC?
Yeah, so unfortunately, there are presently no effective treatments that are known to delay the progression of the disease, and it is 100% progressive. In some people, it's very slow. In others, it's more rapid, but in the vast majority, eventually, they'll have significant scarring and fibrosis that leads to the cirrhosis and the need for liver transplant. So we don't have any effective therapies to slow down those sequence of events. The drug that's been studied the most, mainly in adults, but in addition, some recent pediatric work, is with ursodeoxycholic acid. And with ursodeoxycholic acid, you'll find many studies that show that the liver blood tests improve on ursodiol or ursodeoxycholic acid. However, there's yet to be a study to show that it really impacts long-term outcomes, such as the need for liver transplant or the development of cirrhosis or the development of another complication of PSC, which is a bile duct cancer called cholangiocarcinoma. We found similar results in children. Ursodiol improved the liver tests in the majority, but there's never been a study that looked at it long enough in children to answer the question, does it really change the progression of the disease? In adults, they had looked at it over a longer time frame and found out that ursodiol did not have a positive impact in preventing the progression or the bad outcomes that I just described. The second drug that's had a lot of publicity in pediatrics is oral vancomycin. Vancomycin, an antibiotic that's given by mouth.
Yeah, and particularly in children, I think, isn't it?
Yes, and most of the reports are in children. The theory there is that the antibiotic gets into the colon where it alters the bacterial flora and may inhibit the stimulus for inflammation that eventually feeds back into the liver. I should take a step back. One theory regarding what causes PSC is based on the fact that the majority of patients also have inflammatory bowel disease. And could there be something unique about their bacteria in their colon that are pro-inflammatory, either the bacteria directly or the byproducts that they make are pro-inflammatory, and that those molecules are getting into the liver and stimulating the inflammation that's found in the liver? That's a theory as to, one potential theory as to what causes PSC. So when in pediatrics, when they looked at vancomycin, the theory was, if we inhibit those colonic bacteria, can we lessen the inflammation that eventually is occurring in the liver with PSC? So the problem with all those studies are the vast majority of them are done from a single site, small number of patients, and not placebo controlled, meaning there was no comparison group. It was just a small group of patients. They all got oral vancomycin, and the studies found in this small group of patients that their liver tests improved. However, it wasn't adequately powered for the number of patients to really be confirmatory as to is it a true improvement long term. And there was no placebo group to see was it really due to the drug, or is there the potential that the parameters could have improved just from the placebo effect. So it's inconclusive in my mind. There are some suggestions that it might be beneficial in a subset of children, but if people are really going to consider the use of oral vancomycin in the majority of patients with PSC, further studies have to be done in a large cohort of patients, and it's got to be properly controlled with a placebo group to really determine how potentially beneficial the drug is.
And do other antibiotics work?
Others have been tried. If you look throughout the years, you will see I've seen Bactrim, rifaximin was a more recent one. Many of them will show that the liver numbers come down, but that doesn't necessarily equate with improvement in long-term outcomes. Just because your liver tests improve doesn't mean that you've prevented the subsequent scarring.
I see.
Yeah, so we really don't have a drug that prevents the progression of the disease.
So, if you put in a stat or state into the liver, does that it also doesn't reduce the time to transplant? I suppose, is that the common?
Well, as you know, in primary sclerosing cholangitis, the injury is happening or can happen at all segments of the bile duct tree. So the small, medium, and large bile ducts can be affected where they get scarred and narrowed. And if you have one of those narrowings that is considered a dominant stricture that is very long and very tight, those patients often are very symptomatic. They have extensive itching, they're jaundiced, they may get infection in the biliary tree. In that setting of a symptomatic dominant stricture, you can attempt to balloon it and place a stent into that narrowed segment to help relieve the obstruction. And that's done mainly if the patient is having symptoms. But that is a therapeutic endoscopy technique, but it doesn't reverse or delay the progression of the disease that's naturally happening.
What do most PSC patients die of? Is it infection? Is it cancer? Is it liver failure?
Yeah, so I think that that in children, certainly, we don't see death from PSC because many of the children, approximately 50% of them, are asymptomatic. They don't have any symptoms of the disease. It's a milder form of the disease. And I really believe that the adult form of PSC, where you've got the cirrhotic patient, the odds are that started a long time prior, and even potentially in some cases in childhood. But I think when it's starting in childhood, most of the time it's mild. The study that we did on our 60 kids with it here in Denver, 50% of our cases were completely asymptomatic and had mild disease without significant portal hypertension. Portal hypertension is a sign of the cirrhosis. But as the disease progresses over the decades, you get more scarring and you eventually get cirrhosis and the need for liver transplant. So the death from PSC happens either from decompensated cirrhosis in adulthood while you're waiting for transplant, or the significant increased risk of cholangiocarcinoma, the bile duct cancer, which is extremely rare in children. There's only been about 10 cases in the entire world that have been published on cholangiocarcinoma from PSC in children. That's really an adult complication and is, I think, a testament to the longer you live with the disease, the more likely you are to have cancerous transformation of the biliary tree. So that's really the adults, unfortunately, have to deal with the potential for death from the disease.
And what about infection? Does that
You can get bad infections, and we see that in children as well, because if the bile is not flowing 100% because of the disease, it backs up and becomes stagnant in the biliary tree, and then bacteria from your intestines can get into that biliary tree and cause a bad infection known as cholangitis. And in children, sometimes cholangitis will lead to bacteria that spills over into the bloodstream, and they can get septic. So cholangitis is a complication that you're always looking for when you're caring for someone with PSC. If they have fevers, you've got to go looking for the cholangitis and get them on antibiotics.
I understand, yeah. But do the antibiotics cease to work after a while, or do they keep working?
Oh, so that form, right. So there's, I just want to make sure we're not mixing things up. Some people use non-absorbable antibiotics, such as oral vancomycin, to help prevent progression of disease. Non-absorbable antibiotics like oral vancomycin are not getting absorbed through the intestines. They're not entering the systemic circulation, which is what you would need them to do if you were treating cholangitis. So when I was talking about the oral vancomycin, that's not for treating infection. That some people believe that's a treatment to prevent progression of disease, which really needs further work to know if that's true or not. But if someone has a bacterial cholangitis, you have to treat them with either IV antibiotics or oral antibiotics that are absorbed through the intestinal lining so that they get systemically absorbed and can filter into the filter into the liver, where they can act as antibacterial. So that would be something like oral ciprofloxacin or Bactrim or Augmentin. Those are antibiotics that get into the bloodstream and can kill bacteria associated with cholangitis.
And is there a long-term risk of using those on a prolonged basis,
You wouldn't use them for a prolonged. If you're doing bacterial cholangitis treatment, that's usually a 2-week treatment. So that's not long term. If you're using oral vancomycin, not in the setting of cholangitis, but just oral vancomycin with a theory that maybe it will prevent progression of disease, those studies show that in children, the majority of children need to have the oral vancomycin administered on a daily basis for many years. And that concerns us, that if someone's on an antibiotic that is getting into the colon on a daily basis and impacting your bacterial flora in the colon, could you be setting up that patient for overgrowth of bacteria that are resistant to the oral vancomycin? And so that's one of the reasons why a lot of us are cautious about giving that drug, is because we don't really know what the end point is for oral vancomycin. That the studies really didn't have a firm endpoint. Those kids were often on it for indefinitely or for many years.
Using something like amoxicillin like a low dose on a long-term basis?
So there is the scenario if you've had recurrent bacterial cholangitis, if you had multiple episodes of it, sometimes we will put children on a very low dose of a daily systemically absorbed antibiotic to help prevent recurrence. That's pretty rare in PSC. That's more commonly done in another biliary disease in children called biliary atresia, where we sometimes have to put them on a low dose of antibiotic to help prevent the bacterial cholangitis. But that would be an uncommon treatment plan for PSC in children.
What about liver transplants in children? Is it something that comes up a lot, or you're saying that a lot of it is asymptomatic, but I presume that some children do get very sick?
Right. So yes, approximately 50% are not symptomatic, but then you'll have about a quarter of the kids that have significant symptoms, especially the terrible itching or pruritus that occurs due to the delay in bile flow, and that can be very life-altering. And they may also have significant lethargy that affects their quality of life. So if the child does progress to cirrhosis in childhood or has a debilitating symptom such as the severe pruritus, we will consider liver transplant. On average, from the time of diagnosis to the time of transplant, there's been a couple studies that show in approximately 12 to 14 years from diagnosis, there is an increased risk of needing a transplant. And by the age of 20, approximately 30% of our pediatric patients who have PSC will need a liver transplant. So 30% by the age of 20 years. In the big picture of all our pediatric liver transplants, the indication for transplant due to PSC accounts for approximately 3% of all pediatric liver transplants. So it's a small amount of our total patient population that end up receiving a liver transplant. But for the patient who's got PSC, we tell families about a 30% risk by the time that patient is 20 years old.
Is there so if somebody has a child with PSC, as plenty of people do with PSC Partners, actually, and they're coming to the thing, what should they be looking out for to help their child be as well as possible for as long as possible?
Yeah, so we give them a lot of education up front and teach them the potential complications associated with PSC. So we talk to them about symptoms of the bacterial cholangitis. We screen them for fat-soluble vitamin deficiencies because they're at risk for being deficient in vitamins A, D, E, and K. We educate them about the risk of the cholangiocarcinoma, but try to reassure them that that is extremely rare in the pediatric population. However, we feel obviously it's necessary to let them know that they're at significant risk of that developing in adulthood. And then most of our kids have inflammatory bowel disease when we meet them. However, some children, I would say about 20%, we meet them and diagnose the liver disease first, and then the inflammatory bowel disease gets diagnosed after that, because even if they don't have symptoms, we go looking for it and usually find it through our scoping, the colonoscopy. So that's the type of education and guidance and further workup that we do when we first diagnose someone with PSC. We do educate them that there is no great drug that prevents the progression. We do offer low-dose ursodeoxycholic acid if they have symptoms. If they are itching, sometimes that drug actually helps with the itching, and or if they have significant elevation in liver tests, we may trial it, but we also educate them that there's no data to suggest that it would alter the progression of the disease. And really, I think yeah.
Do you recommend do you recommend to change your diet or anything like that? Is a low fat diet helpful?
In children, yeah, no, in children, we don't. It may be different in adults, but in children, what we want for them is to have a very balanced, varied diet of all the food groups. We want them to eat lean meats and fish because they're still growing. The majority of them haven't completely gone through puberty, and we need them to have a varied diet to ensure that they optimize their health. So we don't restrict any food group or honestly any amounts of food. It's very rare for our children to have ascites formation in childhood from PSC, and so we don't restrict their salt intake either if they don't have ascites. So we want them to eat a variety of foods. We do, of course, in the teenager, we will counsel them on not drinking alcohol, but apart from that, there's no dietary modifications or restrictions.
I see. And is there seems to, at least at the last PSC conference, there was some hope offered that there were treatments that seemed to be 5 to 10 years away that were looking very hopeful. Is this your experience as well?
Well, I think as a pediatric hepatologist, we learn a lot about treatments from the adult trials. With the exception of the oral vancomycin, most of the treatment trials in PSC start with the adult PSC patients, and if there's clues that a drug may be beneficial, then we will trial it in children in the future. And so I know that there's ongoing studies. One drug that has shown some promise is ursodeoxycholic acid. I also know that they're looking at the pathway involved with the bile acid secretion because bile acids may directly be damaging that liver. So agents that help to get the bile acids out of the liver cell and through the bile are being tested. They're FXR agonists, as well as drugs that would inhibit intestinal reabsorption of the bile acids so they can't get back into the liver to cause harm. I know that those are being trialed as well. So I think the future is promising. There's a lot of different pathways that can be targeted to help protect that liver from damage and scarring.
Yeah, good, because there's some drugs being developed for PBC and stuff like that seem to reverse the cirrhosis or help reverse the cirrhosis or slow it down anyway, or the fibrosis of the liver.
Yeah.
Well, is there anything I should have asked that I didn't ask? Is there or anything you'd like to add?
Sure. I think one thing that we would want those interested in learning more about pediatric PSC to know about is that in the United States and Canada, we do have a multi-centered consortium of 13 sites in the United States and Canada that are working through the National Institutes of Health within a consortium known as the Childhood Liver Disease Research Network. This is a network that will, in the next few months, be starting up an observational study for children with PSC that has many aims to it. We want to clearly define the phenotype of pediatric PSC based on their presentation and their outcomes. We want to help these children with their quality of life by doing measurements of global health. How are they with quality of life and frailty? We are also going to be looking at different radiographic modalities to determine what are the best ones in children for accurately assessing the amount of liver scarring or fibrosis. And then the last aim is in this prospective cohort that of children nationwide, we're going to be collecting samples to look at the stool microbiome, to look at their blood inflammatory markers, and see if we can identify clues to the cause of the disease as well as biomarkers of progression.
Sounds
so that's
great.
all. That should hopefully get up and running in the next couple months. We've been working on it for the past year. And then in addition to that, there is, as you mentioned at the beginning of this podcast, the organization PSC Partners Seeking a Cure.
Well, thank you very much, Dr. Mack. This has been very informative.
Sure.
Thank you for your time and obviously for your work in this area.
Sure, my pleasure.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.